I'm going to basically try to tell a story here. Everybody that I run into, even in physicians, is always interested in what can we do with the immune system. And there's a lot of misinformation or incomplete information about what the immune system really does and what it's responsible for and what's involved. This is probably what I call a Pac-Man theory, what a lot of people, even in medicine, think of the immune system as, in fact, what the immune system does in tumor immunology. In that they tend to think of, well, there's this a cell, immune cell, doesn't work, that's it. That's your immune system right there. And what it's supposed to be doing is traveling around and finding a tumor, and once it finds the tumor, it kills the tumor. That is a very simplistic mechanism because the immune cell, in fact, is not a cell, it's a system. And the system in our body is very redundant with multiple pathways. I know Dr. Lau showed you some pathways within a malignant cell itself. I'm going to show you pathways, not that you have to memorize them, of the immune system, what we know now that we didn't know 10 years ago, that we didn't know 5 years ago about the immune system. So there's multiple pathways, there's multiple checkpoints requiring different keys. It's sort of like if any of you have watched The Amazing Race. In order to get to $1 million, you have to go through certain tricks, you have to go through certain pathways, you have to go somewhere. And the immune system is the same way. Along the way of trying to develop an immune response, there's certain checkpoints and pathways where the system can be stopped. Sometimes for good reasons, sometimes for not so good reasons. There's multiple cell types, not just one cell. These cell types will have overlapping functions, and they also have distinct roles. Again, the system is redundant. The communication system is very complex. But more importantly, the system is adaptive, meaning that it can change throughout your life. You're exposed to different bacteria and viruses throughout your life. The immune system can adapt to that. And it tends to be protective. And its normal function is to protect you. But it is complex. And this is a part of the system involved. And what you see here are some of the cells that actually are involved in the immune system, but these are subsets of the cells. So you have T cells, you have B cells, you have dendritic cells, you have basophils, neutrophils. All these interact and communicate with each other by different proteins that they secrete and send to the other members of that system. So there's this cross-communication. It's sort of like me walking up to somebody working at the units for the phone system in my neighborhood with the box off, and you see all those wires, and you ask me, okay, I want to go from point A to point B, how do I go? It's next to impossible for me to understand that at that degree. And in fact, if you look at all these messengers that are in white, those are ones we know. Actually, only about 2 or 3 of those have actually made it into clinical trials. So there's a lot that we don't know and a lot that we're learning. And in fact, I will tell you that the cell at the top, which we believe to be an important cell, the dendritic cell, though it existed in our body forever, 20 years ago, we didn't know what it was. We didn't identify it. So there's a lot that needs to still be learned. And the dendritic cell, to go up to the top, just to show you some of the cells, and actually the dendritic cell under the microscope does look like that. The dendritic cell is important for a variety of reasons. We think it's a very important animal in this system, and I'll show you why. There's helper cells that their main function is not to do much else but help everybody else in the system. There's cytotoxic T lymphocyte, which we think is the end cell. Cytotoxic means cell killing. We think this is a cell that is responsible for killing things, whether they be bacteria, viruses, or other invaders into our body. Dendritic cells, as you can imagine, their higher concentration is where we are exposed to our external environment. So in the skin, in the mouth, in the gut, every part of our body, the lung, where we can be exposed to the external environment, the dendritic cells are very important. But there are other cells. There's B cells, NK cells, NKT cells. A lot of these cells we didn't have nomenclature when I was in medical school a few years ago. There are T cells and null cells, and that was it in the immune system. But we now know that there's cells that have different functions, including T-regulating cells, which I'm going to talk about a little bit more, and other cells that are involved. There are different forms of immune response that we now know. One is what we refer to as the innate immune system. And the innate immune system is what's responsible for immediate response. I like analogies. My football coach long many years ago, believed in the KISS principle. If you haven't heard, keep it simple, stupid. So the immediate response is, if you look at a house on fire, the immediate response of the fire department, the firemen. Okay? They're not interested in what caused it at that point in time. They're not interested in what was the mechanism behind it and how can we prevent future fires. Right then, what they're interested in is putting the fire out and saving the inhabitants that may be in the building. And that's what the innate immune response is. It's the immediate response. You cut yourself. You get a bacterial infection. The first response is this innate immune response. The other one is the adaptive. Okay, the fire's out. Now the inspectors come in, the adaptive system, and they go, okay, what caused this fire? And when we figure out what caused it, can we do something to prevent the next house from going through the same process of putting up or starting a fire? Can we prevent it? Can we adapt to what's happening and prevent it in the future? And all these systems have different cells involved, and they have different communication systems. And they are interreactive. Because when there is a fire, ultimately when the fire gets put out, the fire examiners come in and try to figure it out and adapt to the system. So again, going back to this communication pathway and system that's set up, again, I'm going to focus on the dendritic cell. The dendritic cell is really sort of a matchmaker, if you will. You have T cells, immune cells, different immune cells circulating around, minding their own business, not knowing too much. Then you have an invader. In this case, I'm using a tumor cell. The dendritic cell's responsibility is to introduce the immune system to the invader, or the abnormal cell. And it does that, and I'll show you in various processes. However, if this was all there was, obviously, as you're probably learning by now, we wouldn't be having tumors. This surveillance mechanism would be faultless, and we'd be able to eradicate it. But tumors, as Dr. Lau alluded to, as of all normal cells, have a will to survive. And they do some things I'm going to talk about a little bit that tries to put the system and not make it work. But what happens in this situation? Well, an antigen-presenting cell, APC here in this terms, is a dendritic cell. And what it's doing is the little red circles here represent various proteins that the dendritic cells say, gee, I got this circulating around, and I got these, and I don't think they belong to us. So I'm going to take them to the T cell and say, here, these don't belong to us. You need to recognize these and get rid of them. All I'm here is to introduce you to it. And so the T cells, in an appropriate environment, appropriate receptors, and appropriate molecules, will then go, thank you. I now realize this is a dangerous element here, and I know how to look for it because you told me proteins that tell me that this is a dangerous element. And then the T cell circulates off and tries to find this enemy, if you will, whether it be bacteria or not. To get down a little bit more detail here, what actually happens is the dendritic cells will find tumor cells, if you will, in this situation. And the little purple dots here are actually proteins from that tumor cell that are taken to the lymph node. By the way, just to get rid of another misconception, Dr. Sanjay here, who's a prominent surgeon in this field, my patients always come up, the surgeon took out my lymph node. In the lymph node dissections that are done in melanoma, leaves you with 99.9% of your lymph nodes. Okay? So it's not a detrimental surgical procedure. So you have plenty of lymph nodes. And what happens is the dendritic cells find these foreign proteins, scatter them up, take them to a lymph node, and introduce them to the T cells, and the T, in this particular case, the T helper cell. It says, this guy's bad. This is his hallmark. This is how you identify. This is the street address of this abnormal fellow. That T helper cell will then send signals along with the dendritic cells to the cytotoxic T lymphocytes, which will then circulate around and go, okay, I'm looking for this address. Okay? And once I find it, I'll do what I'm supposed to do, which in this situation is destroy the invader. Again, I use tumor cells, but this applies for bacteria, it applies to viruses also. Well, if the system works, Why do individuals develop cancer? Why do individuals not eradicate cancer? Well, again, there's several reasons for that I'm going to go into. One of them is tumor cells inherently are sitting there in a clump going, here comes the dendritic cell. Okay, everybody mask themselves, hide themselves. Let's try to fool this guy. And it can do that so that the dendritic cell is not fully activated. It will actually travel to the lymph node and say, here's this protein, but leave this guy alone. I've been told it's okay, it's one of us. Okay, leave it alone. And then so the cytotoxic T lymphocytes that are not fully activated, they go, okay, it's sort of one of us. So how does this happen? There are mediated escape mechanisms that we now know, and by no means do we know it fully. But these cells, the malignant cells, look like normal cells. So if you take a melanoma cell, it's basically saying to the dendritic cell, oh, I know you came here, but I'm sorry, I'm not really in a melanoma, which is malignant, I'm monocyte. I'm one of you. And the dendritic cells and the immune system goes, okay, that's cool, we'll leave you alone. We'll let you go. It put out smoke screens. Tumor cells secrete various molecules, short list here, that can suppress the response. It can put into the milieu of where the tumor's at, TGF-beta, IL-10, other molecules that tell the immune system, break down, shut down. Don't do anything locally here, I'm fine. They can also activate and recruit regulatory cells, buddies, if you will. They say, okay, Treg, okay, myeloid-derived suppressor cells, you come here with me, and we'll convince the dendritic cell, you and I together, because they won't believe me alone. You and I together will tell the immune system, shut down, I'm one of you. The clinical trial I'm really wanting to do. So one of the biggest suppressors, at least in the laboratory, myeloid-derived suppressor cells, is phosphodiesterase inhibitors. Nobody knows what phosphodiesterase inhibitor is, unless I give it its other name, Viagra. So this is the system. You have a T helper cell, a cytotoxic T lymphocyte. T helper is trying to tell the cytotoxic T lymphocyte to go ahead and kill the tumor. But then above it, you have this regulatory system that's trying to say, no, don't do that. Back off, it's one of us. It's close enough to us that we think it's one of us. And Treg and neutrophils fighting the activation system to eradicate the tumor. So having said that, you now have a process involved. How can we intervene? And can we intervene? Well, at dendritic cell activation, there are certain things that we know that we can activate dendritic cells. 12 receptor 9 agonists, CD40 agonists. There's a lot of different molecules that we can apply to try to activate these dendritic cells. My screen just went off. Here's the star. At the immunological checkpoints, I'm going to talk about CTLA-4 blockade. But there's other types of blockades involved there. And then at the end point, can we bombard the immune system to try to override all these checkpoints, if you will? And I'm going to talk about interleukin 2, but we'll talk a little bit about adaptive cellular therapy. So what do we know? This is a very adaptive system. It functions the way it does for one normal reason: to prevent your immune system from recognizing yourself and causing an autoimmune disease. We all know individuals who might have one: rheumatoid arthritis, systemic lupus erythematosus, ulcerative colitis. There's a whole host of all these autoimmune diseases where the immune system maybe in that individual has failed to recognize self. But it's there to help us. We know that T cells play a very intriguing and integral role in eliminating tumors. We know dendritic cells are the most effective antigen-presenting cells, recognizing cells that there are now, at least in 2011. I won't offer 2015. Maturation of dendritic cells is very important for a robust T cell response. But tumors can inhibit this whole system. They devise ways to inhibit it. So how do we intervene? I showed you the one slide along the pathways. There's different types of immunotherapy that you'll hear us, those who do this, talk about. One of them is active. active being the part of the physician and the patient, being that we can give agents that directly try to act on the immune system and do something, perturb the immune system, to benefit, hopefully. Interleukin-2 is one. Vaccines, interferon, several of those active, where they're administered actively to an individual to do something positive with their immune system. There's adoptive therapy, where we go, don't even worry about the immune system. We're going to take the immune system in the laboratory, all those cells, do something to them, and then give them back to the individual. And hopefully they'll do what we want them to do. And then there's passive immunity, which really doesn't have a role in per se, in melanoma. But it's where we do things like giving monoclonal antibodies that bind to certain receptors. And most commonly we see this in non-Hodgkin's lymphoma, rituximab and mosunetuzumab. These are molecules that are antibodies that are used to give a passive response to the immune system. So what about active immunotherapy? This is again the administration of immunostimulatory agent. I showed you that diagram with multiple pathways and all these interleukins involved with it. I hope you memorized them all. Interleukin-2 is the one that is approved. I'll go through why. But we've given interleukin-1 to patients, we've given interleukin-12 to patients, we've given interleukin-21 to individuals to see if we can stimulate an immune response by overloading the system, giving the individual doses of interleukin-2 that your body can't possibly produce on its own to try to stimulate the immune system. And then there's vaccine strategies. Chris alluded to some vaccine strategies. My personal apology to you all on vaccine strategies, as Dr. Sondic, I think longer than me, a few years, of trying to figure out how can we vaccinate somebody against the malignancy. And they go, why don't vaccines work? They work great in polio, they work great in other diseases. That's because we're trying to give it to somebody to prevent the disease. You can't give a polio vaccine to somebody who has polio and expect it to work. But we'll overcome that at some point in time. Interleukin-2 is an immunostimulatory cytokine. It activates T cells, it activates natural killer cells within your body. There's actually one targeted therapy. This is the first targeted therapy. Interleukin-2 goes in and binds to an interleukin-2 receptor on T cells, on NK cells. We thought this was great when we first started giving it to individuals. We now know there's an interleukin-2 receptor on T regulatory cells. The T regulatory cells, we'll talk about a little bit later, but they're the ones who say, calm down, everybody. Let's not get out of control here. And they try to dampen the immune system. It was the first administered to individuals in the 1980s. Yes, I look back there, giving it to patients in the 1980s. It took us almost 10, 15 years before it got approved for the treatment of melanoma in the 1990s. Why did it get approved? Several reasons. And I won't go through the whole drug approval process in the United States, but one of them was there was nothing in the 1990s approved for the treatment of melanoma. So everybody looked at this, and what it got approved for is if you look at the white line, okay, this is what we call an oncology survival curve. I apologize for the terminology. But what you see is patients up to 9 years in the white line, those individuals who have what's called a complete response to high-dose interleukin-2 are alive 10, 15 years later without evidence of melanoma. There's some patients who have evidence of metastatic melanoma. But if you also look at the total numbers, those that were able to achieve a complete response were few. I rounded off, it's about 10% in a well-chosen patient population. About 10%, real numbers, about 7% of patients go into a complete response and maintain a complete response out years later. All evidence of disease disappears. The vast majority of patients go through the side effects and toxicities of this agent without deriving that benefit. We have been working, and still somewhat, since 1980 to figure out why is that one patient, that individual responding, and why is it this other one responding? We gave them both the same drug, we gave them both the same, they looked the same. Why is one responding and the other one not? I don't have the answer. What happens when you administer interleukin-2? You broadly activate the immune system. I usually tell individuals that are chosen for interleukin-2 therapy or candidates for it is When you have a bad case of the flu, nausea, vomiting, diarrhea, muscle aches and pains, loss of appetite, fevers and chills, believe it or not, that is not the flu virus causing those symptoms. If you didn't have an immune system, you wouldn't be alive. If you didn't have an immune system, you got the flu. Nothing would happen. Ultimately. What happens is your body's response to that flu virus causes secretion of IL-2, interferon, a whole host of other molecules to try to fight that. And those molecules, what we call a chemokine or cytokine cascade, causes fever, chills, nausea, vomiting, diarrhea, muscle aches and pains. It also causes hypotension, what we call a capillary leak. This is where your blood vessels become permeable to fluid. I mean, anybody who's undergone interleukin 2 knows that you gain 10, 15 pounds during the hospitalization. It's all water weight. It's a very difficult treatment, highly selected patients at highly selected sites that are able to administer this. Because essentially what we're doing is inducing the state, when I talk to other medical students, what I am inducing with interleukin 2 is a picture analogous to somebody who's had septic shock. Septic shock is our body's response to the overwhelming bacterial infection. Most of those patients end up in intensive care unit. But with septic shock, we go, we got antibiotics, let's stop this. Sometimes we're successful, sometimes we're not, most times we are. But what we're trying to do with interleukin 2 is induce a certain state similar to septic shock and maintain it for a period of 5 days. And some patients end up in intensive care unit while receiving this therapy. So it's a highly selected patient population that has chosen to undergo interleukin 2, and it's a highly selected centers. Most of the major comprehensive cancer centers and CI comprehensive cancer centers can administer this therapy. Again, passive immunity, I'm just going to mention is it's a form of giving antibodies that can help the immune system. We don't have antibodies per se, this type of antibody where it activates the immune system to stimulate an immune response. I'm going to pass over. I'm going to talk to you about adaptive immunotherapy because about every, I guess it's becoming more frequent now, but every 6 months there's a major breakthrough. Major news report just recently, headline, being promising therapy for advanced melanoma. It's a trial of 9 patients. 1 patient responded, but it made it to the front of the page. And it was involving adaptive immunotherapy. This is a situation where the physicians, the treatment team, said, we know there's problems with the immune system. Patients with, this is an aside also, those individuals who have advanced melanoma are not inherently immune suppressed. It's a local phenomenon. You still fight bacterial infections, you still fight viral infections. It's a local phenomenon. But what we said with adaptive immunotherapy is we know that trying to stimulate that immune system isn't working in vast majority of patients. So what we're going to do is we're going to take the immune cells out of the individual into the laboratory. And we now have all these different chemical messengers, and we're going to mix up this black box and soup and culture those immune cells in this, get them activated, get them really going, and then give them back to the patient, adaptively transfer them back to the patient. Mostly as a simple blood transfusion. The initial study showed that what we did back in the 1980s were what are called lac cells. Nobody remembers lac cells anymore. But what we did is we took lymphocytes out of individuals, cultured them in hydroxyl-2, activated them in the lab, and then gave them back to the blood transfusion to the individual with IL-2. Not too effective. Didn't do what we wanted to do. Dr. Rosenberg and others have looked at, well, maybe that's the wrong thing, that's too generic. Let's go at the tumor site, because we know when we biopsy tumors that you can see immune cells sitting around the tumor. Not doing too much, but they must have been called there by some reason. So maybe they're more specific cells. They're just not doing what we want to do once they got there. They were called there, but then they forgot what they're supposed to do. So we'll do a biopsy, we'll take the immune cells, isolate those out from the tumor, what are called tumor infiltrating lymphocytes, TILs. We'll do stuff with them in the laboratory and give them back. And again, activity was seen. It's something that those who do tumor analogy refer to as a VIR. We like that. What's VIR? Gee, that was a very interesting response. I don't know why it happened, but it was very interesting. But it was limited. So there's new approaches being looked at now, changing the soup, if you will, of what we're doing with those lymphocytes, or those immune cells. Modifying them genetically. We have them out in the body, we'll do something with them, we'll put genes in to express the proteins we want them to express. All sorts of things are being looked at to see what we can do. So what's the current interest? Again, adoptive immunotherapy is not approved. It's an investigational look at seeing. We don't understand fully about the immune system, but this is what we understand today. This is what we have to act on. I can't act on the things that are going to come out in the next 5 years. I don't know what they are at this point in time. So we re-engineer the immune cells. We take them out. We can put specific molecules into them. We can put DNA into them so that they'll express certain proteins that we want them to express. But still, when we do that, the vast majority of individuals that we give those cells back don't respond. Well, now what we know is that we're dumping those cells that we activated into an individual whose body is trying to shut them down. Okay? You dump them into the bloodstream. They're labeled as, I'm looking for melanoma cells. The immune system's inherently sitting there going, no, they're melanocytes. They're us. Forget it. I'm tamping you down. Okay? So what's being done now? We're looking at ways to eradicate, at least temporarily, that whole immune regulatory system that's involved in it. So that when we take the cells out, manipulate them in the laboratory, and before we give them back to that individual, we will totally wipe out their immune system, including the immune regulatory. So that the only immune system that's there temporarily is the one that we've adoptively transferred back. It's been done with high-dose chemotherapy, similar to what an individual undergoing a bone marrow transplant. It's been done with chemotherapy and radiation therapy to eradicate the lymph node cells. And also it's been done with various immune modulatory cytokines. We don't know. We don't have the optimal treatment at this point in time. But it is an area of great research. So, again, I mentioned the immune modulatory cytokines. And I'm going to bring you up to the drug that was recently approved for the treatment of advanced melanoma to sort of understand what it is. The immune system is very regulated, very functional, very adaptive. The minute it gets turned on by some external signal or internal signal, the body's response is, let's cool this off. Okay? Reason being is because if you get an infection locally, you want the immune system to be activated there. You don't want that immune system that's activated to go all over the place and attack other organs. Go willy-nilly. Boy, I'm really turned on. I don't care. I'm bullying the block. I'll just wipe out anything you bump into. You don't want that. So the immune system normally puts its brakes on and says, let's keep this localized. Okay, I don't want you going off crazy and attacking somebody's joints. I don't want you going off attacking somebody's heart, somebody's lung, somebody's brain. I want you just right here. So there's an immune regulatory system set up. It's a normal function. It's there to protect you, to prevent autoimmunity and keep responses local. There's natural receptors, CTLA4 and PD1, that are involved in this process. There's probably others. What happens, and I brought this from a social medical ASCO because the American Society of Clinical Oncology meeting, Dr. Lau talked about this going to happen in June. What I'm missing here is when the dendritic cell, again, the matchmaker, presents the foreign protein, the antigen, to a T cell, what it also does is presents another co-stimulatory signal that binds to CD28. That CD28 and T cell receptor complex activates the T cell. The minute the T cell becomes activated, it produces the receptor CTLA4. So I got activated now, I got a tam down system because if I travel anywhere else, I don't want to be doing anything. And then CTLA4 is activated. And that modulates the negative effect on the T cell response. So what has been done is molecules have been developed, antibodies in this case, not like passive immunity, that have been developed to sort of sit on that CTLA4 receptor and prevent anything from binding to it. And what this allows is the B7 and the MHC to activate, keep an activating signal for these cells. to damage at least one of the immune regulatory systems we know about. So CTLA-4 blockade with monoclonal antibodies blocks this inhibitory signal, and therefore we hope continues sustained activation and proliferation. Two agents have been involved, ipilimumab and tremelimumab. I don't name these drug companies do, but there is a reason behind it. You ever see these nomenclatures? If it has an AD, MAB at the end, it's a monoclonal antibody, so it's got a long name that says MAP. Bevacizumab, other MAPs, there's monoclonal antibody. If it's a NIP, NID, NIP, it's a small molecule inhibitor. Your just got approved by FDA last week for the treatment. Why didn't it get approved? Well, it got approved for the treatment of advanced metastatic melanoma. Its improvement was based on the fact that it improved the survival of those individuals getting the drug versus those that didn't get the drug. Clinical trials done, Dr. Lau showed you some of the clinical trials, we do comparative. We do those trials for simple reasons because what we think, or what we think we know, is not always reality. And so when this trial went on, they gave patients ipilimumab, and some patients didn't get ipilimumab. They got a vaccine. And what they showed is the patients who got ipilimumab lived longer than those individuals who just got the vaccine. But only 10% of patients actually showed shrinkage. So Dr. Logan referred to the BRAF inhibitors, where we saw shrinkage in 70 to 80% of individuals. And we think shrinkage is what equates to you doing better, somebody doing better. That's not always the case. What they showed was about a third of the patients, even though they didn't have shrinkage with these agents, had control of the disease. Kept it from growing. It was still there. You can still see it. But it controlled it for a period of time, and these patients did better. But what we also saw with this agent, similar to the other immunological agents that we have, IL-2, is there's a very small subset of patients where the disease actually does go away. Evidence of it goes away. You can't find it. Very small percentage of patients, less than 5%. Why don't the other 95? We don't know. We're working on that one too. But the responses are what we call durable. So go back. What's this monoclonal antibody? It's blocking a regulatory system. It's blocking one of the regulatory systems. So if you block the immune regulatory system, which protects you against autoimmunity, what are the side effects of this therapy? What I refer to as the itis. You get dermatitis, colitis, thyroiditis, pancreatitis, nephritis, epischleritis, right? Itis is nothing as a term for inflammation. But what we see is patients who develop an immune reaction against certain parts of their body that are self, that are known. So when we see dermatitis or dermatological changes, we sometimes see individuals get what's called vitiligo, which is a loss or patchy loss of melanocytes. Because the body now goes, okay, I'm going to fight melanoma. But darn it, if this melanocyte doesn't look close to this, well, I just better knock it out just to be sure. Okay, so you lose pigmentation. You get colitis. Normally, your colon, as you can imagine, is constantly fighting invasion by bacteria. Your colon is loaded with bacteria. Your body is loaded with bacteria. And they're sort of in equilibrium. But if you release that equilibrium and stimulate the immune system and shut off this regulatory system, you get colitis. Diarrhea, abdominal cramp. It can be severe. Patients need to be watched. You can get inflammation and immune response against your liver, hepatitis, against your pancreatitis. These are extremely rare. When we grade toxicities, these are physicians grading the toxicity, by the way, not patients. So it doesn't look that bad to me. Any grade, about 80% will exhibit one or more of these. Okay? But when you get to grade 3, that's what physicians consider severe. I guess it's grade 1 and grade 2 is about either. But when you get to grade 3, these are serious. These are life-threatening complications from this treatment. About 20% of individuals get it. Okay? And in fact, unfortunately, what we saw, patients died from this therapy. Small, very small, 2%. What people did when we manipulated the immune system with our inexact knowledge, patients can suffer greatly from it. Again, it's a drug that is out there, it's available, just got approved, and it is of some benefit. How do you manage the side effects? What we call these side effects, the normal nomenclature in oncology, when we call side effect, is an SAE, which is a serious adverse event. We don't, in immunology, it's serious, that sounds bad. We're going to call them immune-related adverse events, IRAs, okay? And it's seen as a result of stimulating the immune system. The onset can vary from patient to patient. It can wax and wane in an individual. You get diarrhea, the diarrhea goes away, you get diarrhea, goes on. You can get the vitiligo. But when we look back, it looks like those individuals who got some type of immune-related adverse event were much more likely to develop a benefit from Melanoma in that case. Not 100% correlation. I had patients who were treated with Melanoma who had lungs, the other agent, had a long-term event and didn't even birth while they had that. Okay? But again, a very, very small fraction, but we do know some things about it. So what can we say? Well, there's been small effects. We've been doing this for over 25 years now. Yeah, 25. And we've seen small advances that are looking through. Ipilimumab. There's something going on. There's some VIRs in there that seem to benefit, very interesting responses that seem to benefit in certain individuals. We can't predefine who those individuals are. We can't say, as Dr. Lau alluded to with BRAF inhibitors, you have this, therefore you will respond. It's probably because of, even though I showed you that complicated network, it's much more complicated than that than we actually realize. So on my slide, we got any complications that didn't come out, but that's okay. But what immunotherapy is the only modality that results in permanent disease control in a small subset of patients. So it keeps us and keeps our patients very interested in, is this a modality for me? And again, the knowledge of the immune response to cancer continues to expand. We're left with this. This is a small window of a larger diagram I have of how the immune system interacts with it. It's small, showing the communication system. There are lines to be drawn in there and molecules that have yet to be discovered. They're in us. We haven't isolated yet. We haven't figured out what they're doing.